Traditionally, cardiology focused in standard practices to rely on how tight and narrowing that was created by plaque in a heart artery. I don't think that's the approach we need to take. LDL is the one molecule that predominantly contributes to the atherosclerotic plaque formation in the heart arteries and other arteries in the body. If you focus on LDL alone as a number, yes, we have achieved the target number for a particular risk factor, but we haven't addressed how much of the LDL that caused the plaque and how much of that plaque is biologically active, how much of it is causing inflammation. Majority of the heart attacks happen in people with non-obstructive, meaning they have plaque not causing severe blockage but causing a heart attack. Their chance of having a heart attack is 1.6%. So when LDL numbers are down to the targets, how do you measure their risk?
Welcome to Cardio Now, and today we're tackling one of the most important questions in heart health, and one that almost never gets answered at a standard checkup. What number should your LDL actually be? And not the population average that your doctor circles on a lab report, your actual number based on your arteries, your plaque, and your inflammation burden. Because it turns out that the target is different for everyone, and the only way to find it is to look in the right places. So, Dr. Mulumudi, let's get into it. It's nice to see you again, as always.
Thank you.
All right, so let's dive in. So I know LDL is something people hear and may or may not fully understand, but most people have been given an LDL target by their doctor at some point, may be familiar with that. Under 130, under 100. But where do those numbers actually come from? And why do you think that they're actually often the wrong starting point?
The number comes from the risk, meaning that if they had a heart attack in the past, if they have coronary artery disease, they have it presently. And that's what dictates the number. If you think about it, low LDL is generally better for people who have any plaque or any coronary artery disease. That's how these numbers come from. When you look at the population studies and look at people with X number of LDL concentration in their bloodstream have this many number of cardiac events. So you come to an intersection point where the LDL number will have the lowest cardiac events. That's how these numbers are picked out from both the studies and population studies and all the research trials. That's how these numbers come from. Are they the right thing? Are they what we should be following? Should this be individualized for a particular patient? Is always been a debate, and cardiology is moving in that direction, making these LDL numbers personalized, meaning very individualized for a patient and for their risk and for their biology and for their metabolism. So that's where we're heading.
Absolutely. And you use the phrase plaque burden determines your LDL target. So can you break that down? And what does plaque burden actually mean? And how does it really change the number that you're chasing?
So I'll focus on the plaque burden itself, and then we can talk about the LDL numbers. So looking at the plaque burden, if you look at an individual that doesn't have plaque at all in their heart arteries, their chance of having a heart attack is 0.2%. If somebody has plaque in their coronary arteries, their chance of having heart attack is 1.6%. That's 8 times. So it's important to understand the presence of plaque it is essential to identify the presence of plaque so we can come up with interventions or treatments that can address the plaque and hence reduce their chance of heart attacks and strokes and so on. So that is where it is necessary for us to know the plaque burden and to proceed with what kind of therapies and lifestyle changes we can suggest, leading a better life and less incidence of heart attack for a particular patient.
And then there's some tiers within this, I believe. So can you walk us through some of the tiers themselves? And if someone is at home wondering what category they fall into, what does each level actually mean for the number that they should be hitting? Can you go a little bit deeper into that and explain more about that?
Traditionally, cardiology focused and continues to focus even today in standard practices to rely on how tight a narrowing is, how tight a narrowing that was created by plaque in a heart artery was an old approach. That means that we are looking for only plaque that is causing symptoms. And that's why we're looking for the tightness of the blockage and then treating the blockage. We used to do stress tests to identify the degree of narrowing or causing any ischemia, meaning reduced blood flow to a segment, and treating them. Is this the right approach? Is the main question in front of us today. I don't think that's the approach we need to take. And I'm not alone in this particular campaign to reduce the heart attacks and deaths from heart attacks. If you think about it, people without any plaque in the heart arteries, their chance of having a heart attack or dying from a heart attack is 0.2%. Majority of the heart attacks happen in people with non-obstructive, meaning they have plaque, not causing severe blockage, but causing a heart attack. Their chance of having a heart attack or mortality from a heart attack is 1.6%. Think of that, it's 8 times. So knowing the presence or absence of plaque is very important in today's world of cardiology therapy and treatments.
Absolutely. And then we haven't touched much on this yet, but plaque regression. So let's talk about that a little bit and what plaque regression actually means. Because this is something that I think most patients have never heard is even possible. I know I, for one, haven't heard about this. So can plaque actually shrink?
It's a answer is maybe,
Mhm.
and there is evidence now pointing towards how plaque burden can be reduced in a patient. There's one trial called Reduce It, REDUCIT, Reduce It trial. In this trial, patients, in addition to their standard treatments, received concentrated extracts of omega 3 fatty acids. It's kind of a concentrated form of one part of pentyethyl. That's a kind of omega 3 fatty acid that's concentrated. They have given 4 grams of this to the patients and checked their heart attack, angina, and hospitalization and death risk. It's called a composite endpoint, meaning they put everything together and see how many people are affected by this set of variables. They found out their risk is reduced by 25%. That tells that there is something changing in their coronary arteries when they receive these omega 3 fatty acid extracts that resulted in the reduction. A subsequent trial is called the Evaporate, and it's nice. They are talking about evaporating the plaque. They looked at the plaque that has low attenuation, meaning the plaque that is not dense, that's kind of lucent on the CT scans. They looked at that. They measured the plaque volume in patients that received these concentrated extracts of omega 3 fatty acid. When they were followed through, patients that received these concentrated omega 3 fatty acids had a 17% reduction of this lucent low attenuation plaque. Whereas people that received the placebo, the plaque doubled. What this means is we had the Reduce It trial that showed the events are going down with the concentrated omega 3 fatty acids. Now we have a mechanism to show why it happened because the low attenuation plaque reduced by 17% with the treatment. So we have a trial that showed the effect and trial that showed the mechanism of taking concentrated omega 3 fats and how it reduces the plaque volume and hence reduces the heart attacks and mortality as a combined endpoint.
Let's talk a little bit about LDL. I think we mentioned it in a previous episode, but not right now. We haven't talked too much about it. So, with LDL, well, if it's being well controlled, some patients still have significant residual risk. So, what's driving that and how does inflammation fit back into the picture here?
LDL is the one molecule that predominantly contributes to the atherosclerotic plaque formation in the heart arteries and other arteries in the body. If you focus on LDL alone as a number, yes, we have achieved the target number for a particular risk factor, but we haven't addressed how much of the LDL that caused the plaque and how much of that plaque is biologically active, how much of it is causing inflammation. Atherosclerosis in the end is an inflammatory condition. If you have LDL to the target, if the inflammation is still present, that means that we have to do something further to calm down the inflammation and reduce the risk of heart attacks. How do we measure that is the question. So when LDL numbers are down to the targets, how do you measure their risk? The standard has been using CRP, which is an inflammatory marker that gives us if the plaque is being inflammatory or not. But the problem with CRP is CRP goes up with any inflammation in the body. If you have joint pain from osteoarthritis, that can make the inflammation go up and CRP goes. So CRP is an indicator, but it's a non-specific indicator. It can go up with multiple things. There are markers, for example, LPPLA2. LPPLA2 is a marker that tends to increase only with vascular inflammation. If that marker is up, even when LDL is well under control to the target numbers, that means that there is active inflammation and we need to treat that further to calm down the inflammation.
Absolutely. And there's also something else that I think you've mentioned before, colchicine.
Colchicine, yeah. So the
And
reason why I mentioned colchicine is research now to point out that if there is increased inflammation, in spite of the LDLs coming to the target numbers, that means we need to treat the inflammation. And one of the ways to do it is to take or to treat with colchicine. Colchicine calms down the inflammation and has shown to reduce the chance of heart attack as we follow that. So that's one way of calming the inflammation. And there are several medications that are out in the trials looking at ways of reducing inflammation in the plaque, even when LDL is controlled. So we're coming to that phase where novel molecules are going to be available for us to be utilizing for treatments. But for now, colchicine is readily available and it is effective for people with controlled LDL still having inflammation as identified by increased inflammatory markers.
and speaking about that, I know that that medication is or used to be known as a gout drug. So how did it really get into cardiology?
There are the paradigm shift that happened in cardiology with atherosclerosis is identifying it's not a passive deposition of bad cholesterol. It's actually an inflammatory process that results in heart attacks from the plaque. That led to investigating and looking at medications that are anti-inflammatory. Colchicine is one of those medications that's a chronic anti-inflammation medications with minimal side effects. That's why colchicine was studied and shown to reduce the chance of heart attacks in these folks.
Then going a little bit beyond that, what other tools exist to address the inflammation piece, both pharmaceutical and or lifestyle based?
So the tools exist to treat inflammation, if you ask me. So pharmacologic, as we talked about, one is colchicine is a good medication and proven to reduce heart attacks. Again, remember, this is the category of patients that have controlled LDL, but high inflammatory markers, and they benefit from colchicine. The lifestyle changes that can be utilized to reduce the risk of heart attack in these patients and reduce inflammation in the body. Number one is exercise is the greatest anti-inflammatory agent out there. If you think about this, any form of exercise will definitely reduce anti-inflammation. The second part is fine-tuning our glucose metabolism in the body. Even though somebody is not a frank diabetic, if they have impaired glucose tolerance, there is inflammation. That kind of inflammation, that kind of ongoing metabolic changes that drives the cholesterol into the cells, that can be addressed with exercise, diet, especially low carb, high protein diet. And I'm a big fan of promoting exercise after eating. The reason is most of us subscribe to a exercise regimen that you do in the morning, you do in the evening, and we think that we did 30 minutes a day or even 1 hour a day. But remember, we're eating between. When our glucose metabolism is not so well tuned, what we have to really do is reduce the glucose peaks when we eat because elevated glucose peaks are inflammatory in many ways. And they're also capable of driving bad cholesterol into the cells, forming atherosclerosis. So what you're really doing is by exercising after every meal, we are flattening these glucose peaks, hence reducing their ability to drive cholesterol into the cells. That's where the main difference comes from. So when
And
you ask me the inflammation controlling changes, one is diet and exercise. Of course, pharmaceuticals, as we talked about. Go ahead.
absolutely. And speaking a little bit about cholesterol, LPA is something we haven't talked too much about, but I know that you've mentioned previously that it's a genetic rogue actor of cholesterol. So, what is it exactly, and who should be tested for it, and why does it change the treatment picture overall?
So LP little a Every LDL molecule has a lipoprotein attached to it. Most of the lipoproteins that we have is lipoprotein B. Lipoprotein A is a variant that is genetically determined, and it has been identified as an independent risk factor. These Lp(a) molecules are slightly different compared to the traditional lipoprotein and LDL particles. They have the ability to penetrate the cells and cause atherosclerosis. So this is a genetically determined number most of the time, and everyone needs to be tested for it at least once. The most common thing that people will talk about is you'll have a lipoprotein a, LPA, and that is elevated, say 100. A few years down the road, they'll check again, it will be 200. The most common question is if it is genetically driven, why is the number changing for me? To answer that question, any change in body's metabolism, meaning that you are becoming a diabetic, you have an infection, somebody is pregnant, somebody is postmenopausal, all these different changes cause the LP(a) to go up. So it's natural for the LP(a) to fluctuate to some extent. Also keep in mind, LP(a) is measured by different methodologies among different labs. The numbers may slightly vary from one laboratory to the other, but in general, LPA is a genetically determined molecule. That's the concentration that we have.
Absolutely. And we haven't talked a lot about this yet, but APOB alongside LDL, a lot of listeners have maybe heard of APOB or maybe not, but why does it matter and why isn't it the standard cholesterol panel?
It's becoming a standard these days, which is good news. Apolipoprotein B, and the short of it is ApoB. ApoB, every LDL particle has apolipoprotein B that wraps it. By measuring the ApoB, what you're measuring is the LDL particle numbers in a way. In a way, you're getting how many LDL particles exist. Even the LDL concentration is low or optimal, they may have high ApoB, which is indicative of high LDL particles. So if somebody has LDL particles measured, knowing ApoB concentration may not mean much because we already have the LDL particles, which is giving you the direct information rather than a surrogate marker, which is the ApoB.
Absolutely. And then if someone walks away from this episode and they really want to have a different kind of conversation with their doctor, what does that conversation look like? And what would you recommend that they ask for?
I would suggest to anyone who wants to talk about their cholesterol numbers, their goals, and how do you measure them accurately, please ask the physicians that you're going to consult with. Getting the standard LDL, HDL, and total cholesterol and triglyceride concentrations. Definitely get the lipoprotein A at least one time checked. Check ApoB or apolipoprotein B to understand your LDL particle numbers. That's the first one that I do. I would also suggest getting the HSCRP, which is high sensitivity CRP, C-reactive protein, so that you know whether there's inflammation or not having inflammation. If there is further interest and if your physician feels appropriate, I would suggest definitely get your NMR lipid profile, which will give you the number of particles and the particle sizes, meaning what is the number of LDL particles that you have and what is the particle size. You want the LDL particles to be low in number, larger ones are fluffy, benign kind. So I would approach treatment of cholesterol with those numbers in hand so that the treatment can be targeted and treatment can be very specific, that is aimed at a person as an individualized therapy rather than a blanket treatment for cholesterol.
Before we do wrap up the episode, are there any other things that you want to add in that you think would be helpful for listeners to know?
I think we talked about a few things today. And in the next episode, I really want to talk about what are the tools available to measure the plaque and how do we characterize the plaque. That's what we are focusing on these days. I will talk about that during the next episode when we get together. But I believe we talked about how to go about risk. What about cholesterol? What about inflammation? How to go about treating that?
Absolutely. No, that's great. And thank you so much for all the information that you did provide today. And I think one of the key takeaways is that heart disease doesn't announce itself, it really builds quietly. And that's really the whole point of everything that we talked about today. The plaque builds quietly. So the inflammation burns quietly and the risk grows quietly. until it doesn't have to anymore because you decided to take a look. And that's very crucial and necessary information for everyone to hear. And thank you again, Dr. Mulumudi, and thank you for all that you mentioned and for everything that you laid out today. It isn't complicated. It's actually pretty straightforward once you know what to look for, know your real numbers, understand what's in your arteries, set a target that actually reflects your biology, not a population average. And if inflammation burden is still there, even after the cholesterol is controlled, address that as well. It's not some radical idea. It's just medicine done the way it should be done. So thank you again for spending this time with us on Cardio Now. And if today's conversation made you think differently about your own heart health, share it with someone who needs to hear it, and make sure you follow us wherever you get your podcast so you don't miss what's coming next. It's going to be another great episode. And thank you again, and we'll chat soon.
Thank you so much.